Hello, everyone, and welcome to Conversion. Thanks for having me here today. As a quick background, I'm an telecom engineer, started my career in Infosys, spun off a startup in the telecom space called On Mobile in about the year 2000. So 2008, that company went public. 2010, I kind of decided I wanted to do something with more social impact. So worked with Aadhaar for a couple of years. And then I've started a chain of eye hospitals. So in Karnataka, I run about 12 different eye hospitals, mostly in tier 2 towns of Karnataka. But for the last 3 years, I've been working on health, especially digital health, given my background. So been part of a not-for-profit think tank called iSpirit. And we have been working very closely with the government to kind of define how health or health technology can actually make a difference for healthcare. So starting with what was called the National Health Stack documents, the National Digital Health Blueprint, and now the National Digital Health Mission, I've been closely working with the government to try to bring to life many of these. So we'll talk a bit more about that kind of today. So I am officially an advisor to the National Health Authority, which is implementing this. So Priya, do you think I can get started? Anything else, or shall I get started with the presentation?
Yes, I think we can get started. We are good.
All right, let me share my screen. So the topic that we're going to pick for today is, how we can reimagine healthcare with what's called the National Digital Health Mission. So I'll spend a few minutes kind of trying to talk about what is the National Digital Health Mission. And it was, many of you might be aware, that was actually launched by the Prime Minister on August 15th. He announced the concept of a health ID for everyone from the Red Fort this time. It's actually been implemented by the National Health Authority. The policy part is run by the Ministry of Health and Family Welfare, while the National Health Authority actually runs the implementation kind of on the ground. And as Priya was sharing, consists of a whole bunch of digital building blocks. So what's an interesting question to ask is, what are these digital building blocks that actually make a difference for healthcare? So we'll learn a bit more about those building blocks. But before we jump into that, let's look at what were the guiding principles that have been kind of enshrined into the National Digital Health Mission. So first and foremost, that it's completely voluntary. So it's quite challenging. So there is not expected to be too many laws or too many, pushes that get people on board. So it means that every element of the National Digital Health Mission has to be built with a view that there are strong incentives for people to participate. And privacy and security are absolutely of concern. And I think as with anything, like dealing with data and especially health data, there is going to be many different viewpoints, especially on privacy and security. And so we'll talk a bit about how the National Digital Health Mission views it. But most important thing that you should understand is that the mission puts the control of the health data in the citizens' hands. So everything is about you having control and you deciding what you want to do with your health data. There are a few other principles, not as much to kind of touch upon. Most are easy to understand, but the last one, which is wellness centric, is quite important. Worldwide, there is a movement that today most of healthcare is about curative, and the question is, can we shift behaviors so that we are more wellness centric, because that's the only way you can keep the overall cost of healthcare down as India moves towards universal health coverage. Now, building blocks is what we use. So what are building blocks? So building blocks are fundamentally digital components. So essentially, every block you see here on the screen does one thing, has a clearly defined role, has a whole bunch of APIs. So we call these as digital public goods. So similar to just like a road is something that's a public good that's built, can be used by anybody. These digital public goods are supposed to be built by the government, but supposed to be used by anyone in the private ecosystem to get some benefits. So there are 5 of these that we have launched as part of what we call as phase 1. They consist of the health ID, which is a way to digitally identify an individual in a health transaction. There is the health professional registry. So we started with doctors. So there is a way to identify doctors in the context of a digital health transaction. For example, you can visualize it in the case of telemedicine. And then of course, which is the participating facility where this transaction actually happens. So the health facility registry does that. The key thing that brings what we call as a longitudinal health record of an individual together is actually done by the consent manager and gateway. And so I'll cover that in a bit as to how that works, but these are just the initial building blocks. The National Digital Health Mission will have a fairly long life. So We are looking at many other blocks coming. Next up are areas that we're working on telemedicine, on health claims, on drug registry, e-pharmacy, health analytics, and so on. So over the next decade, you're going to see the National Digital Health Mission make significant differences in terms of what it does on various things on the healthcare side. Let's talk a bit about health ID so that you can understand it. So, and there's a lot of question or usually as to, why yet another ID when we have Aadhaar. Most of you should know that post the 2018 Supreme Court ruling, there are actually a significant amount of restrictions on use of Aadhaar, but I'm happy to share that, Health ID, the way we have designed it, you can actually get your health ID by just using your name, year of birth, gender, or mobile. So you don't need anything more than these four pieces of information. You can optionally provide your Aadhaar. In fact, if you do not have a mobile phone, you can just use your Aadhaar to get it. It, like in UPI, looks like something that you choose yourself. Like I've chosen mine as Kiran MA at NDHM. At NDHM actually refers to the consent manager that manages this health ID, and associated with the health ID, apart from something that I can easily remember, is also like a 14-digit random number, which is a number that can also be used instead of wherever I use my alias. Now, the whole idea of the health ID is that as we move forward, our behavior will shift where we'll walk into a healthcare location and we'll probably just share our health ID. So today, like you make even a pani puri wala, you just pull out your phone, you scan a little QR code. It's likely that you'll just walk into a hospital, scan a QR code to share your health ID and get registered. And by design, you can have more than health ID. So similar to just like simple analogies like your bank accounts, you can have more than one bank account. You can think of your health records like your money. You can keep some of it in each of these health IDs, but you can also move it all into one. For longitudinal health records, it's always better to have one ID. So we have many mechanisms to kind of make sure that we educate you that it's better for you to have one ID, but it's not enforced. It is something that we want users to actively learn. We also think that there may be many use cases in healthcare where people may actually want to have two. And you can think of these cases, things like mental health records, information about sexual health information, abortions, and so on. So there are lots of sensitive data where people may not want to actually keep everything in one health record in the Indian context. So how do you get one? So you can get it yourself. It's quite easy. You can just go to the site healthid.ndhm.gov.in and you can just get it on any mobile phone. It's right now live and available in several of the UTs. So it will show you a pop-up saying, please register only if you're from one of these UTs. And in the future, you'll also get it whenever you visit a hospital. So participating healthcare providers will actually issue a health ID. So that's how this is being visualized. It is not likely to have like only for people without phones. We think there'll be a physical form like a card. Most others will just have it as part of a integrated mobile application that they will carry on their phones, right? So far, we have already issued about 3 lakh health IDs in various UTs. Now, let's step a little more into understanding how NDHM actually helps you build your longitudinal health record. In healthcare, people say that access to your history or longitudinal history is one of the most critical things. And the way we visualize this is through a construct where we are saying that there'll be a class of players that we call as health repository providers coming in. So imagine that there is a hospital or a diagnostic center and it has a piece of software. We are looking at how can this software actually hold your health records for the long term. So when that software can hold your health records for the long term, we call them health repository providers. So participating hospitals, diagnostics, clinics will generally have to choose some software, and that software will have to keep your health records for a long time. So you can mentally visualize that, your records are kind of spread across various healthcare providers where you sought treatment in some sense. And what these HRPs do is they actually link the fact that they're holding a health record with something that we call as the consent manager. So you provide your health ID. And so what the consent manager knows is that against your health ID, say diagnostic center X holds some OPD records. It doesn't really know what's in those records. Some hospital, there is some other thing in hospital Y and so on. So essentially the consent manager and your health ID just provide an index to where your records are spread across the ecosystem. So we call this a federated architecture. And essentially what this means is that when you want to see your longitudinal record, you actually pull all of the data from all of these HRPs into one longitudinal view. So the person who's pulling it in, so you can have anyone actually seeing your health record with your consent. So we call those users who are trying to look at your detailed health record as health information users in our architecture. And those can only be done with consent. So that's a mental picture I wanted you folks to have. And so this picture kind of gives it better. So on the left side, you have a whole bunch of hospitals, diagnostic centers, and clinics. They're likely to have some software, and we are looking at whatever software they use today to actually become NDHM compliant, which makes sure that they're holding your health records. Now, whenever they're holding a health record, and most commonly we think initially what is already digital is what will actually be used in the participation. So if you take any user's file and you start flipping through those files, you're likely to see mostly in India diagnostic reports which are printed and generated on a computer. You're going to see essentially discharge summaries that are probably printed out. In a rare case, you might see a prescription which is not handwritten, or a consultation note that's not handwritten. Now, what we would like is that the sharing of this data actually happen in a reasonably standardized format. So when we know that India is not going to, it's going to take quite a bit of time and some challenges for India to move to a completely standardized, highly structured data format. So what we have done is we have used FHIR, which is a it's an international standard for health data formats. Of course, it has more things than health data formats, but we have adopted the health data format of this. And we are expecting that whenever any of these health repository providers share data, they will be sharing it in one of these NDHM profiles. So that's the other thing that's expected. You can take an existing PDF document you have, put a FHIR wrapper around it and share it. But in 3 years, we'll expect you to kind of also move to far more structured data. And when we say structured data, for example, if you're looking at a lab test report, what we're looking at is that you can actually have the line items also coded using a standard health data terminology. Now, on the right side is where you have the health information user. So even if you're looking at your health data on a mobile app, that would need to implement a specification that we call as a health information user specification. And that's how it would get access to data. And we also have another construct that we call as a health locker. So since we have a federated architecture, most users may also want to store their own data. So the health locker is your personal store where you can actually pull all of these health data and keep a copy. And so whenever you're sharing, you'll get a choice that the HIU can get the data from the federated architecture, or it can get a copy from your personal health locker. Now, very recently, I went and I actually got a COVID test done. And so many of you might have had this experience too in this world of COVID. At the end of the period, I got an SMS, and then I went to the lab provider's website. I put the code that I got on my SMS, and I was able to see a PDF of my report. Now, this is good. That means it's already a digital experience for all of us. We are able to kind of get health data access digitally. The negative is that it didn't really add to my longitudinal record. In about a year from now, it's unlikely that I have this code and it's not really becoming part of my history. Now, the shift that we are asking for with NDHM is that the same lab essentially make a minor change. So not only does it continue to share that SMS with me, where I can go to their website and see it, but it actually also links that record, collects a health ID from me and links that record with my consent manager so that it becomes part of my history. And when it shares that record, not just share it as a PDF, but also as a structured data that makes it easy for machine readability. So that's the shift that NDHM is expecting. Now, with that background, I think it's time to think about, how is this actually going to change or reimagine how our healthcare experiences are going to be. I'll just use a few terminologies just to finish up on this. So we talked about how facilities who start sharing digital data will become health information providers. The software that they use and hold that health data will be called health repository providers, and then anybody using health data are called health information users. Now, the NDHM architecture means that any hospital, any lab, any software can actually do this. So similar to how in the UPI world, you can use today any mobile application to pay anyone, and it's a completely interoperable payment ecosystem. Similarly, NDHM has been called the UPI of healthcare, where any software from any hospital or lab will be able to kind of interoperate with any HIU or anybody who wants to view or process your records. Now let's understand how this is actually going to change the hospital experience. So when a hospital or a lab decides to kind of participate in NDHM and registers itself with the facility registry, you will be able to walk into the hospital, pull out your phone, there's probably going to be they're going to be able to scan your health ID, or you're going to be just able to scan something that's a sticker that is sitting on the counter so that you can share your health ID, which means that the hospital gets all of your details accurately, knows you how to contact you digitally. There are no errors in that process, and it also simplifies time, because for long hospitals with large queues, this can be really useful. Now, the next thing that you'll experience is that the hospital will probably send you a request saying, hey, I want to access your medical history. So you will get something that we call as a consent request. And the consent request will say, Tata Memorial Hospital wants to take a look at your history for the last 5 years or so. And you will have the control. So on your mobile app, you will be able to actually control and say, okay, I'm willing to give access to my data, and I'm willing to give it only for this period of time. And I only want to give access to this data. So the control on what health data is provided to the ecosystem actually rests with the user. And then once you do that, and when you walk in to see the doctor, it's likely that the doctor has your history up. And we think that there's now going to be a whole set of tools that doctors will start getting access to, which will look at your history and then help the doctor provide better care based on your history. And then if the doctor then does a prescription or basically does a medical test or a report, you're going to have that back onto your history. It's going to pop up on your phone, and you're going to never be able to kind of lose it in terms of the process. So you can visualize this very quickly as to how this is going to happen. And this is what we call as the personal health information journey. Now, NDHM is not just about personal health information. It also deals with what we call as aggregated and anonymized data sets. And so every lab, so the simplest way to imagine this is every lab that participates in NDHM not only allows for, say, the data of a patient to be shared in a standardized format, but it also provides certain anonymized data, it's not anonymized, sorry, aggregated data every day. So for example, it would report how many HbA1c tests did I do yesterday, and how many of them were outside the normal range. So there is absolutely no personal information. It's just an aggregation of all of the data. So you can visualize, if we were able to get aggregated data from every lab, and if most of the labs in the country are participating, what's the power of the data? So while personal data kind of makes you get empowered, gets you better treatment, aggregated data will help in different things, from epidemic tracking to better health policy making. So you will be able to actually say, what's the right place to do it. And the other thing that NDHM will also enable is what we call as anonymized data sets. And anonymized data sets are very important. So for example, in this case of COVID, there would have been a huge value if we could get labeled chest x-rays and CT scans without personal information that could be used by training sets. So because even if you go to the smallest of town today, you're likely to find an x-ray, almost a digital x-ray today, but you may not find a radiologist who works in that town. But software can then start doing much better analysis and decisions if you can actually create these sets and make it available to the ecosystem so that they can actually create fascinating new solutions on the top of this. So NDHM is going to be able to do not just personal data movement, but also these two kind of health data in the overall architecture. I'll talk a bit about other areas that NDHM is working on. So for example, one of the things that it will do is simplify health claims processing. I don't know how often many of you have experienced health claims processing in a modern hospital today, but many of these large hospitals have these huge rooms called TPA rooms, and almost every claim that is processed is done on paper. So, they will still fill a paper out, or they will fill out a web form, and it's completely non-standardized, so to speak. And so the average cost of processing a health claim in India is today over 700 rupees. So you can't actually process, for example, an OPD claim because it's way too expensive. The average cost of an OPD claim is likely to be about 500 rupees in India. So to be able to do that, NDHM is building something we call as a health claims platform. It's also standardizing the input. So there is a standard that we now define called an e-claim document. And it's also going to standardize things like the e-discharge summary. This has already been done under NDHM. And it will allow the hospital to create this e-claim form using any software it wants. So one piece of software, and that same claim format can be used for every insurer, public or private, in the country. You submit it to the health claims platform. It looks at, hey, who's supposed to process this, routes it to the appropriate payer or processor. And now, because it's completely digital, it means that the payer or processor can actually have tools that do better things like auto adjudication, which is automatically make a decision. So just to help you understand this, in most markets, including Western markets, over 90% of health claims are completely auto-adjudicated with absolutely no human intervention. And that can only happen if we are digital, and that's what will drop the claims. It's also super critical if we have to go towards what's called as universal health coverage. So this is the second area that it does. And it also helps authorities actually monitor SLAs. So for example, are you getting paid on time? Did you get the pre-auth in time? How long did it take between the time the doctor told you can discharge and the time you could actually go home, and so on. So this is one more area that NDHM is kind of going to work on. It's also going to change how contracting is done. If many of you know, typically contracts in the health insurance world are tripartite, signed between the hospital, the insurer, and the TPA. And I run hospitals, as I said, I have about 12 of them, and I can tell you that there are about 32 different insurers and TPAs, and for each insurer or TPA, they make me cut one small tree with the size of the documents that they sign. So we hope to change that with completely e-sign and a contracting system, and let's really hope that we can save some trees on that process. Uh, we talked a bit about registries in the early days. So we said that one of the things that NDHM does is that NDHM makes sure that every entity is identified. So a health ID is a way you identify a patient. And we said that there are registries that identify facilities as well as doctors. So there are some principles that we do. So the core thing in any registry is finding a way to establish trust. So how do you verify, for example, if that somebody is really a doctor? So we want to be sure that, for example, their registration is verified by the certifying board. And then you need to have, because it's all voluntary, you need to have strong incentive mechanisms. So why should a doctor actually sign up and be part of a registry? Why should a facility sign up and be part of a registry? And how do you actually get people to start using all these APIs so that they can actually use it in their app? So creating that is one of the big key challenges of NDHM. I'll just tell you a little bit of how we're thinking about it. For example, in the case of doctors, so we do have separate views in terms of how it should be for students. So India has, for example, about 2 lakh medical students a year. So we would want them to sign up when they're still a student. And essentially, the college would say, confirm, yes, this person is actually studying with us and this is what he's studying. So you would actually know. So for example, today, India cannot answer how many specialists are there for, say, vitreoretina specialists, and where are they actually practicing. So we don't know if we need more or less of what. And so all of these kind of things will be much better answered when you have strong registries. So once the college confirms, the student would also be able to apply online for any registration completely digitally to the medical councils. They would issue the medical number again through the system, and then the data would flow to the national medical councils, making sure that you have very strong trusted data, but it also kind of digitizes the flows. We have similar things that we are saying that practicing doctors can do, but most importantly, by signing up for the registry, we are going to give them several benefits, including simple ways by which they can actually e-sign for documents or discharge summaries. They can collect their CME points and so on. Very similar approach is what we are taking for the health facility registry. We are saying we would like health facilities to actually participate. So since there are a lot of information, so for example, one of the things that happens is that any hospital requires several licenses, and it requires also several deals with several insurance empanelments, and all of them ask for the same data over and over again, and in all kind of different forms and formats. So what we are doing is, in the health facility registry, we are actually standardizing the health information that would be collected and verified for a health facility. And then we are working with all sets of licensing and certification authorities. We have identified almost 40 different licensing and certification authorities, over 30 different health organizations, and over 10 different government health schemes that want more or less portions of this health data. And we are saying we would make all of the digital. So none of them, once you get your health facility verified, have all of the data correctly captured in the standard format, you can apply for any of these licenses completely digitally online, and you will not need to file any paper. And it'll make the process stronger and simpler, but it'll also mean that India is going to have very good quality data on the health facilities and what kind of facilities are actually there, and it will be strongly verified. So this is another example of how NDHM is actually going to change health data. So we have talked about a lot, so I would like to kind of bring this talk to a close, saying that as you can see, NDHM is really trying to create an ecosystem, and kickstarting a new digital ecosystem is never easy. So one of the approaches that we are taking to do that is to create something that we call as Sandbox. So you can go check out sandbox.ndhm.gov.in. It's actually open to anyone. So anybody can enroll. All you need to be is a registered entity in India to be able to do it. All of these building blocks are available on there. The APIs for them, the documentation for them are available there. And right now, while we are able to go to production primarily in the UTs, we'll be expecting to go national with NDHM in a few months. And in about a year to 2 years from now, I think many of the benefits that I spoke about should be available to most people who are residing in India and should be able to experience some portion of NDHM in their life. Now, the thing that's making me really happy is that while we are only in the UTs for a pilot, we are seeing extremely active participation from top players, whether it's from government, because we need to get the government systems to actually integrate with our software. And we are seeing that very strongly with software that's used in public hospital like AIMS or PGI Chandigarh, which is called e-hospital or e-Shushruth. They're all integrated already with our programs. Then we are having top hospitals and corporate chains from Columbia Asia to Dr. Lal Path Labs coming and integrating. And then we have several suppliers of software to hospitals and labs from Live Health to Practo and so on, who are also integrating with it. So as these people integrate, test against these APIs and make them available in the market, we think that this ecosystem will start to emerge. So we think that about in the pilot phase, up to about 80 different facilities may actually have this go live, and we will actually see how this ideas that we are putting up here work really on the ground, and then learn from that feedback before we actually help take this whole thing national. So happy to share with you. I don't know how many of you know. I'm sure there are several of the Thoughtworks team listening in. Many of these ideas, this big vision of making a change and a difference for this country, has not been a short journey. iSpirit, which is the not-for-profit foundation that I've been part of, and Thoughtworks have been very much part of it. I would encourage many of you to look at Project Eka, an open source implementation of these ideas that was built by the Thoughtworks team, and in fact is the foundation source code base from which even the National Digital Health Mission's components have been built off. So I think it's been wonderful, and I'd like to call out Anshuman and many others who have been actively working on the design side of the thinking, pushing the curve so that we can actually have great solutions for this country from your own team. So really appreciative of the support. So even today, Thoughtworks is a key partner and has been supporting many of the initiatives at the National Digital Health Mission. So very happy for that. So with that, I'd like to bring this talk to a close, and I can see that the Q&A section has been buzzing a bit. So I'll let Priya take a look at it, and we'll answer any questions. Thank you.
We have loads for you, and I think we even have time to go through them. So I'm just going to call out the ones which have the maximum votes, Kiran, and you can answer them online. Plus, as we had discussed, we also have a Slack channel. So the ones which don't get answered here, we'll be pasting it there.
Sure.
So the first one talks about how supportive are current government initiatives as we aspire for digital health ecosystem in India. How much more needs to be done?
Yeah, so I think, folks, if you look at the Aadhaar journey, Aadhaar started in 2009 when I worked there between 2010 to 2012. But by the time we actually got to 1 billion Indians, it was close to 8 years. The UPI journey today is, I think, more than 6 years old. So we are like in our infancy in many ways. And the healthcare ecosystem is, I think, also far more complex in terms of the number of players. Like in the case of UPI primarily had to integrate with banks, which is again a limited handset of people. Here we think we may have to have about 100,000 different institutions to come up. So our government supportive, absolutely. You will see that the National Digital Health Mission is being directly monitored and being looked at by the Prime Minister's office. It is seen as a very critical program of the country, and pretty much every health program of the government, from the mother and child program, the upcoming vaccination drive, everything will actually use NDHM and participate in it. So you will see a government push for it. It's likely in the future you'll also see certain government incentives for private participation to happen. Now, digital healthcare is not going to really if there is no clinic or a hospital in a village, just because it's digital, it's unlikely it's going to change unless we think telemedicine or other things can actually bring that kind of a change. So I think that's an evolving question as to, healthcare in the remotest parts of the country. Even today, one of the things that keep coming up in our discussions, because, we launched in the UTs, and the UTs include Andaman, Nicobar, Ladakh. And so connectivity in these places is actually quite challenging. So one of the things that we are hitting in our field tests is, still poor connectivity, low connectivity in many areas. And can the National Digital Health Mission and the building blocks really deliver value even in those kind of situations? So I think you should not worry about that part. And I think we will see significant support from government.
Great. Kiran, the next one says, who has and how have they decided what is privacy for Indian society? I have taken a huge assumption that the Indian society definition of privacy is very different from a Western one.
Yeah, it's a brilliant question. And I think it's a great thing to talk about too. So I think India definitely is treading a different path on data privacy compared to, say, whether it's the US HIPAA or the European GDPR. And I think those interested should look and get a good understanding on how our personal data protection bill is structured. So let's take, for example, health data, and let's ask questions. For example, who owns health data? So if you read the privacy bill, you'll find that they kind of nicely sidestep the word ownership, because the doctor could say, look, I wrote that prescription, this is mine. You as a patient could say, but that data features me, so it's mine. So what the bill instead does, it focuses on what rights do you have if your information is part of it. So it essentially puts an onus on people who are creating health data which has personal information to meet certain fiduciary responsibilities. So essentially it says, look, without that user's consent, you cannot use, share, or show this data in any way or for any purpose other than for the purpose that which was authorized for your use. So the National Digital Health Mission actually builds on this concept, the whole idea of a consent-based model. So for example, in the National Digital Health Mission, you could actually authorize a hospital to have your access to your data just for a day, which means at the end of the day, the next day, they would have to actually delete your data. So in many ways, what this also means is that by putting the user in the center. So for example, in the US, when two institutions have to exchange health data, they don't even think about the user. I mean, there's no user consent on that side. Their electronic health information exchanges are largely designed for saying, okay, we need to move the data around kind of a thing. In the NHS in the UK, they have a view that, for example, a doctor should have full rights to see your full health data, even if you don't kind of want it. So, different countries have swung differently, and we still don't know how India is going to fully play this out. But the architecture is such that we are okay to go in whichever direction, but fundamentally still keep the user in control of their data. I hope that kind of helps answer that query.
Yes. Okay, we can take one more. What are the security measures after giving access to hospitals for the health industry?
Yeah. So like I said, under NDHM, we know who the entities are. So, any access is always to a certified entity in the NDHM ecosystem. And certification essentially means that the HIU in this case, so the health information user in this case, will essentially meet the consent, essentially implement software and follow policies in such a way so that it actually meets whatever is the consent guidelines that they're collecting on. So if the consent I have provided is just for, like I said, for a day, then that they're actually deleting the data after a day and so on. So that's what certification takes place. And then you have a grievance method to make sure that if somebody does take the certification, then starts violating, you have the law as well as the policies that make sure that A, they can be taken out of the system, and B, there can be penal provisions on them from a law perspective. So those are the two ways in which security is being kind of handled.
Thank you. We'll take one more. It talks about, can NDHM be classified as a comprehensive health information technology or an HIT system?
Hard to, I think, NDHM, like I said, is a bunch of building blocks. So for example, what you should know is that when health information moves from a hospital to even a mobile phone or another hospital, the building blocks more acts like a control layer. So it has no access to health data. So NDHM itself does not have access to any personal health data. At best, it has only access to the aggregated data stream that we talked about for policy making. So there is, by design, we are trying to come up with an architecture where the government or any entity cannot really create one single system which has huge amounts of health data, say, that maybe make it much easier to hack, or also have lots of issues on compromising of privacy and security. So not very sure about if I would call it a comprehensive health information technology system, but more of an architecture that helps empower movement of health data while keeping security and privacy in the front. On Bala's question, I think I'll just take up on hiding sensitive diagnostic information. The answer is yes, but it is at the discretion of the patient. So, because you control what data you make visible. So the way we are currently thinking about it is that, let us say you had a bunch of health records. When you're sharing your health records with your doctor, you can say, okay, I don't want to share anything, but I want to share just a small portion of it. But we think, and this is still being debated, we may want to at least let the doctor know that not all records came in. So because the doctor may also need to take a position. So for example, if you were to hide, I run eye hospitals, if you were to hide your cardiology information from an eye hospital before a surgery, there is a risk in the surgery. And so this is an area that's going to have a large amount of debate. But yes, that capability to hide it is there in the hands of the patient.
Yeah, I think we can take one more. I have an interesting one here. It talks about how do we bring connectivity between each and every small medical centers where there's no software infrastructure. And it talks about inclusivity for everyone, not just the privileged ones.
Sure. So look, I think, I keep saying this, you imagine that you're going to start something new today, whether it's in government or whether it's in private. IT has, when you think forward, IT is going to be all pervasive, is going to meet, most parts of our life. So the bet that we are taking, so the National Digital Health Mission is not trying to say that, look, I have this doctor here who's still writing his prescription on a pad, let me go solve his problem first. So instead, we are going the other end. We are saying, what's the low-hanging fruit? What's already digital? How can we actually get that's already digital first to come into standardized formats and become available so that the ecosystem can build? And our thesis is that when you start seeing the value of some of these things come out, more and more things, the adoption, the rate of change of adoption of digital will also go up, right? So I give an example which I think will make sense to many of you folks. The RBI opened up licensing for banks today, and so many people got licenses called small finance banks. Can you imagine a new small finance bank? Maybe it's doing much smaller than somebody which is a very large bank. Start a bank today without an ATM and an internet banking option. It can't, because the consumer expectation today is that, hey, ATMs and internet banking is important. So our thesis is that if you were to get pretty much all of the public systems, pretty much, and the top corporate chains and those who are already digital online, and even let's say that ends up being just 1/3 of the healthcare in the country or even lesser, it starts to create an experience and a consumer experience which the rest who are not providing it will hopefully want to adopt. And that is when we think that change of adoption into healthcare for digital healthcare will happen. We think that India is a very innovative country. We think there will be a whole class of players who will come in to service those who are not yet digital. So I do think, and I have met many startups in India who are actually building solutions for the small doctor, the small lab, the small clinic. And I think many of those will actually get an impetus or a push because of the National Digital Health Mission.
Okay. I think still have a few questions. We'll paste them on the Slack channel. Kiran, it will be great.
Right. Thanks so much, Priya.
Thank you. Thank you so much, Kiran. This has been truly insightful. Thank you.
Right. Bye.